our evening sessions. So I'll be cordially inviting Dr. Prakash Nair sir for his lecture on endoscopic endonasal approach to Petrus apex pathologies. Please, sir.
A very good evening to all of you, and thank you for this opportunity to come here and speak to you on this Petrus apex and the endonasal approach to the Petrus apex. So, okay, so I think in the morning we've had a wonderful set of cadaveric demonstrations on the approach to the Petrus apex, and सुनो इसमें नहीं आ रहा है इसमें नहीं आ रहा है ठीक है कोई बात नहीं So, the skull-base chondrosarcoma probably forms a tumor which could be identified as a prototype for tumors that go and grow into the Petrus apex. There are several other conditions like cholesteatomas also that involve the Petrus apex. And these are three examples of a variety of tumors that involve the Petrus apex and extend either superiorly or inferiorly and are very approachable through a direct endoscopic endonasal approach. Pointer है किस pointer है? Now, we've had a very detailed discussion in the morning regarding the cadaveric anatomy. So I shall try to focus on certain clinical examples that can be utilized to explain how the endonasal approach can be used to approach tumors like this that involve the Petrus apex, the upper part of the clivus, and the petroclival skin chondrosis. And this should be seen as one unit lateral to the midline behind the internal carotid artery that can be approached using the endoscopic approach. So the key to this, as we saw in the morning, were these two important structures, the Vidian nerve and the pterygosphenoidal fissure. And these two anatomical structures can be used to triangulate upon the laceral segment and the genu of the ICA, which can then take us posteriorly towards the Petrus apex. So one of the important things for any tumor that involves the upper part of the cavernous sinus and the posterior clinoid is also to be able to mobilize the medial wall of the cavernous sinus and to identify the keratocondyloid ligament and the inferior hypophyseal artery that will also lie in this course. So the key steps for this involve a maxillary antrostomy and then ligation of the sphenopalatine artery, then sectioning of the Vidian nerve, and then identification of the foramen lacerum and the genu of the ICA. So here we first go on to do a maxillary antrostomy, a wide maxillary antrostomy, and then identify the sphenopalatine artery as it comes out of the sphenopalatine foramen. Once the sphenopalatine artery has been identified, we can coagulate this and then open the sphenopalatine foramen to identify the sphenopalatine ganglion, which can be retracted. Now, once this is coagulated and divided, we can also make another incision to complete our posterior septectomy so that it gives us bilateral access. Now, at this point of time, the Vidian nerve is being identified, coagulated and cut. Once the Vidian nerve has been identified, coagulated and cut, we can retract the sphenopalatine ganglion towards one side and then drill superiorly here to identify the foramen rotundum and the maxillary nerve. So one can appreciate the maxillary nerve as it comes out of the foramen rotundum, and then this bone removal can be taken further anteriorly to open the Meckel's cave. Now, this is the Vidian neurectomy being done, and this exposes the pterygoid ridge. So we get more and more exposure towards the lateral aspect of the sphenoid sinus and towards the ICA. Now, the next step is probably more daunting. This is the part where we skeletonize the entire ICA and we open both superiorly and inferiorly. So this is the lingual process. The lingual process is being fractured and removed, and the entire ICA has been skeletonized. Now we can drill towards the medial aspect. So one can appreciate the entire course of the ICA. You can use the Doppler to insonate the ICA and identify where the cavernous sinus can be opened. And the opening is made here at the junction between the inferior intercavernous sinus and the cavernous sinus. So this is an area where you have some dead space, which can then be filled with Surgiflow. So the anterior part of the cavernous sinus is opened, and as we expose superiorly, Again, this is the genu of the ICA. We can identify the keratoclinoidal ligament. So this is the CCL. And once the CCL has been identified and cut, the entire posterior aspect of the cavernous sinus and the clinoid comes into view. You can identify these branches of the inferior hypophyseal artery that are coagulated and cut. And now the posterior clinoid has been visualized, and the posterior clinoid can be detached and removed. So the posterior clinoid is being detached away from the upper part of the clivus, and then it can be slowly fractured down. So this is the first part where the upper clinoid, the upper part of the clivus, the dorsum and the posterior clinoid is being removed. And this can be done along with the peeling of the meningeal layer of the dura. So this gives us an additional margin into the posterior aspect. Now we come to this petrosal process of the sphenoid bone. Danny had shown us a little earlier about how this is a very vital landmark for identifying where the sixth nerve is. So we have electrophysiology going on at this point of time. This is the petrosal process that is being identified, and the bone can slowly be disarticulated. And we use electrophysiology, we use this stimulation probe to identify the course of the sixth nerve. So the sixth nerve then comes into view here. So this becomes very important because this is an area where the sixth nerve can be injured. This patient had presented to us with sixth nerve palsy, so one can appreciate the course of the sixth nerve there. Because we have stimulation going on, we are also able to directly stimulate it. And now we drill towards the petrous apex. So this is the internal carotid artery. This is the petrous apex being drilled. And this gives us a greater margin of bone resection. So we all know that tumors like chondrosarcomas respond very poorly to RT. You need proton beam and doses of 70 Gray. And for young female patients like this, it gives us the chance of getting a curative resection. So this is a post-operative image. One can see the entire tumor which has been resected. And this brings us to the second case. Now we have this tumor which is again involving the posterior clinoid, but also involving the entire petroclival synchondrosis. And there is greater involvement up to the upper part of the petrous apex, again in a very young patient. So this is a tumor that is located slightly lower down. And here we use two important landmarks, the pterygosphenoidal fissure and the Vidian nerve. So these can be used as a GPS where you can triangulate it towards the foramen lacerum. And this is the still that shows the pterygoid wedge, the Vidian nerve that has already been cut. So at this point of time, we've now done the initial exposure that I tried to show you earlier. I'm now detaching the posterior clinoid, and here the bone, the outer periosteum of the bone forms a nice margin for resection. So the first bit of tumor has been resected. This is a very young male patient, so there's a very interesting anatomy where you can see the cartilage and the fibrous fissures also. So now we are drilling towards the petrous apex inferiorly. The entire ICA has been exposed. Again, we are now dislodging the petrosal process of sphenoid bone, and here we will be able to identify the sixth nerve using electrophysiology. So whenever we get venous bleeding, we use gel foam to stop the venous bleeding. And as we drill posteriorly, now this is drilling the upper surface of the petrous apex. Now, as he's a child, you can appreciate a very interesting this. We can see the petroclival fissure, we can see the petrous apex, and the petrosal process of sphenoid bone being disarticulated here. These small bits of bone can be removed to get wider resection. And you can see the clivus, you can see the petrous apex, and the petroclival fissure in between. So being a young, this is not a structure that you will normally see in adults because bones tend to be much more, seem to have fused by then. But in young children, one can appreciate this distinction. So in the CT, you can appreciate how the drilling can be carried on to the upper aspect of the petrous. And this again gives us a very wide resection margin. So this is a post-operative image where one can see that, we have good resection after surgical removal. So this was a study that was carried out by Sami Youssef et al. And they compared the extent of drilling that one would get with a classical transcranial petrosectomy, which is being shown here, versus what you would get with an endonasal petrosectomy, which is being shown here. So most of the area and volume that is covered with a transcranial petrosectomy happens in the upper aspect of the petrous and is limited by the internal auditory canal, whereas the endonasal petrosectomy is a more inferior and medial corridor towards getting an access towards the petrous apex, and is probably more important for getting access both inferiorly and superiorly for tumors like chondrosarcomas, which essentially grow along the petroclival synchondrosis. So this is another example of a patient who now has tumor involving the petrous apex and then growing inferiorly towards the anterior aspect of the jugular bulb here. Now, in tumors like this, one should also be careful about seeing how the ICA can sometimes come very close anteriorly up to the eustachian tube. So when the eustachian tube is being mobilized for access inferiorly, one must be aware of this relationship. Sometimes it can be a result of an ICA injury. So here, once again, the median nerve is being cut. And the exposure here takes us inferiorly. We now remove the bone over the anterior aspect of the ICA. And here the tumor has already filled this space. It gives us some gap between the bone and the ICA. This is the anterior surface of the eustachian tube, which has been mobilized to some extent. It has not been transected. And then because this bone is, the destroyed bone is soft, we use a combination of curette and suction to remove the bone. The drill is used to get further bony resection inferiorly, and small bits of tumor that now invade the soft tissue are also resected. So this gives us an opportunity to also remove the bone, the tumor that invades the soft tissue of this petrous apex and the eustachian tube. So one can appreciate the posterior fossa dura here, and by navigation one can also see that we've almost reached the anterior aspect of the jugular bulb there. So this is the postoperative image. At nearly 3 years he continues to be in remission. And one can appreciate how inferiorly the resection is carried out, so that the tumor resection goes on almost inferiorly to the anterior aspect of the jugular bulb and the foramen lacerum there. So the aim of this was to show you how the endonasal approach can be used to get to these tumors that lie on the petrous apex, involve the petroclival synchondrosis, either extend superiorly or inferiorly. And the classical tumor that can be used for managing this is the chondrosarcoma. Now, this is a much larger example. So, you have a very large petroclival chondrosarcoma involving the petrous apex almost up to the upper aspect of the IAC, but also forming a very large bony chunk involving the prepontine cistern. So, here, after very wide exposure, we open the anterior aspect of the cavernous sinus. Here again by opening at the junction between the inferior intercavernous and the cavernous sinus. We open the anterior wall of the cavernous sinus and then work in this interdural plane. Slowly go posteriorly to identify the inferior hypophyseal artery, which has to be coagulated. So venous bleeding that we encounter can be managed using injectable gel foam. And once this has been done, we get to the posterior clinoid that lies here. Now, for chondrosarcomas where we plan upper clivectomy, the posterior clinoid and the dorsum are areas where we might have residual tumor. And unless we do an interdural approach and open that particular area, we might have residual tumor at the end of surgery. So here small bits of tumor are again being removed. This is the dorsum being slowly mobilized away, peeled away from the meningeal layer of the dura. And because these bits can be quite large, we alternate using drilling and removal of these bits so as to not place pressure upon the part of tumor that is in the prepontine cistern. So once this has been done, we go on to open the dura of the clivus. So this is the interdural, this is the part which is in the prepontine cistern being removed. And at the end of resection, one can appreciate the brainstem and the basilar artery here. Further, dural margins are resected to get a wider resection. Now, this is the postoperative image. One can see that the tumor in the prepontine cistern and the upper part of the clivus is removed. But then there is a certain amount of residue that lies lateral to the surgical field. And for tumors like chondrosarcomas, we might require multiple approaches, including an open approach, to get to this particular part of tumor. So this is another example where we can have large tumors, and for the want of time, I shall skip the video. Again, a tumor that involves the upper part of the clivus, the upper part of the petrous apex, and extends onto the petrous apex here with displacement of the ICA laterally. So because the ICA is displaced laterally, once we detach the ICA and the anterior wall of the cavernous sinus, this can give us direct access to the entire tumor. and also allow us to remove the soft tissue component. So this is the wide margin of resection one gets at the end of surgery. And this is the 3D reconstruction of how the skull base looks after resection has been achieved. So there are many approaches to the petrous apex. You have the anterior approach or the approach through the anterior petrosectomy or through the translabyrinthine approach, and they have their own advantages and disadvantages. So when we come through an anterior transpetrosal approach, there is a certain amount of limitation to get to the middlemost aspect of the clivus. And when we come through the posterior transpetrosal approach, there is a certain amount of risk of hearing, and at the end, the resection rates remain very limited. So to conclude, these are management modalities that we use for chondrosarcomas. The management of any tumor in the petrous apex, including a chondrosarcoma, is multimodal. But the endoscopic approach gives us a very direct access to tumors that involve the petrous apex and the clivus, which are essentially extradural tumors. The Vidian nerve is a very key landmark. The combination of the Vidian nerve and the pterygosphenoidal fissure can be used to consistently identify the foramen lacerum and the petrous apex behind that. And this can be used for extending our approach further to the jugular foramen or to the infratemporal fossa. So we get wider resections and wider corridors. Thank you.
Thank you, sir. Next, I'll invite Dr. S.S. Dandapani, sir, for his lecture on endoscopic endonasal approaches to cavernous sinus.
It has come. Good evening, everyone. Respected teachers, my dear friends. I would like to thank Dr. Jaskaran, Professor Deepak Jasar, Dr. Bhaskar for inviting us to this very theme-based meeting. And I think we all enjoyed today's dissection, and it's very nice that very focused conference, very kind of focusing on advanced endoscopy and also the transorbital approaches. So thank you very much. So I'd like to focus on our philosophy of endonasal endoscopy for NOS4 ICA encasement in cases of pituitary tumors. Sometimes we wonder in such tumors, kind of whether should we do aggressive surgery at all, or we can just remove the cellular part and then give gamma knife or radiation. So whenever we are considering such kind of cavernous sinus invasion with a complete encasement of ICA, what we follow is we do aggressive surgery as much as possible because of three main reasons. First, in cases of functioning tumors, the more aggressive surgery you do, you give them increased longevity, especially cases like acromegaly, like in this patient. Second, many of these patients have symptoms of third nerve or sixth nerve compression. So that one, if you do an aggressive surgery, you can cause improvement in their deficits. And also visual deficits, we do, kind of definitely do surgery to decompress these nerves. But whenever we have a complete encasement, when the tumor goes lateral to the cavernous carotid artery, sometimes there is a debate. Some people say that you don't have to aggressively chase these tumors, but I'll just show some of the cases, illustrations, and leave how much aggressive to do in your hands. That is an individual institute-wise decision depending upon the patient's symptom. Sometime back when we had done this meta-analysis, we noted that intentional entry into the cavernous sinus per se doesn't increase the mortality or morbidity of surgery. And the more and more of cavernous sinuses we open, we tend to have increased likelihood of gross total resection, and we noted after 20 cases of a good transcavernous exposure, the GTR likelihood ratio increases. And also we had noted that, as I have already highlighted, that and many of you may agree with me that sometime when we don't want to enter or expose the cavernous carotid artery, still we can get carotid artery injury. But when you intentionally open, you take more precautions and you are more careful, you do in a methodical way. So we have hardly encountered any carotid artery injury when we had planned and intentionally opened up. So this was one case in which a conventional, a medial transcavernous approach without any transpterygoid kind of variations, we can see that the complete ICA is exposed. We can see this is the ascending segment and this is the posterior genome. This is the horizontal segment of cavernous carotid artery and the anterior genome is here. And the 4 compartments which Dr. Jaskaran was highlighting today, we can see all the compartments in a single view. This was using a 30-degree angled endoscope. So the compartment which is inferior to the horizontal segment is the inferior compartment, this whole space, and the area which is lateral to the carotid is the lateral compartment. 6th nerve you see here, inferolateral trunk is not obvious but it was here, and posterior compartment is here and superior compartment is here. And 3rd nerve enters the interdural space just lateral to the posterior clinoid. So 3rd nerve is an interdural structure in the cavernous sinus. So whenever there is a deficit, we have to go in just lateral to the posterior clinoid area. Sometimes there may be erosion of the roof of the cavernous sinus and the tumor may go beyond this. Otherwise, if it is a simple compression, the decompression would be easier. But 6th nerve is within the cavernous sinus, so we have to be extremely careful, because that a kind of undue dissection can cause worsening of 6th nerve palsy. So this is the rationale, and in most of the cases, like compared to the previous presentation, kind of wonderfully demonstrating the anatomical dissection, whenever we are dealing with pituitary tumors, the good thing is that the tumor itself gives you a corridor. So that will teach you which trajectory to take and how much you can be aggressive. So some of the cases I'll just show. And another thing is that the advantage of endoscopy lies here, that you are able to have the possibility of using angled optics, and you can go more lateral, and even with navigation and angled endoscope, the outcome of patients with cavernous sinus invasion is better than when we don't use these things. And entry, whenever we are entering into the cavernous sinus, we cannot give a cruciate incision because the medial wall of the cavernous sinus is strongly adherent laterally using with the help of paracellular ligaments, but the ligaments which are holding the pituitary to the medial wall, they are flimsy pituitary ligaments. So by entering here, it is very difficult to peel off the medial wall of the cavernous sinus. So the only way to peel off the medial wall of the cavernous sinus is to go lateral. So the incision should be lateral, and then after entering, you can dissect it and follow the ways. So this is a typical case in which the cavernous sinus invasion, we routinely do CT angiography guided navigation. And as you see, we can plan most of the things here itself. And whenever we have to give a dural opening over the carotid artery, as you can see, this is the vertical segment, posterior genome, horizontal, and this is the anterior genome. So this area, there is so much of tumor. I think Dr. Prakash also had highlighted. This is a very safe area. So here, there is so much space, so you can confidently cut the dura across the carotid artery. But here, the tumor is also not there and the space is also very limited. There is no need, as well as we should not open the dura here because this will be risky. But here you can be more confident. And also, the displacement of the horizontal segment of the cavernous carotid artery will tell you which trajectory will give you better yield. like most of the things can be done by a transcellular or medial transcavernous exposure. You can remove the inferior compartment, you can remove tumor in the posterior compartment and superior compartment. And in this, if you take this trajectory, both the inferior compartment and posterior compartment will be taken care of. And whenever there is a significant lateral portion, whenever there is a tumor lateral to the ICA, then you have to do for transpterygoid exposure and have a lateral exposure so that you can enter here. But the problem is sixth nerve injury is highly likely if we are doing it without neuromonitoring. So whenever we are doing a lateral entry, we have to be careful because sixth nerve is within. But third nerve compression you can easily tackle, as I have already highlighted how to do it. This was some time back when we did a cadaveric dissection. Some of the things had already been shown today. So this is the area where we enter. This is the carotid artery and this is the CCL, and this can be dissected and cut, and you get the inferior hypophyseal artery from the meningohypophyseal trunk and posterior clinoid you see here. And the third nerve is always entering the interdural space from the cisternal space just lateral to the posterior clinoid. So that is the area first we'll have to decompress whenever there is a deficit. And I'll just skip these portions. See, and this is the lateral portion for the lateral transcavernous approach. Sixth nerve is here. And in the this is the medial transcavernous approach, but the bony exposure should be kind of extensive so that mobilizing carotid laterally is easier, but you'll have to ligate and cut the inferior hypophyseal artery. And as the posterior clinoid, just lateral to the posterior clinoid, you can see the third nerve entering. This is the cisternal part of the third nerve. Here it is entering the interdural part. And lateral, you can do it under neuromonitoring, but we have to be careful because sixth nerve injury is possible when we are careless. So it can be a medial exploration or anteroinferior or lateral exploration. For anteroinferior and lateral exploration, you need a tailored transpterygoid approach. So for a lateral transpterygoid and lateral transcavernous approach, I'll just kind of illustrate with this case. These are the routine steps which has been covered previously. So we need a good transpterygoid exposure and navigation based exposure of the tumor area. And here, as you see, we open the dura as I was showing in the CT angiography navigation. This tumor was already coming out of the dura, and we opened from there and we went across the cavernous carotid artery, and like a U, this is the anterior genu. That area I am not opening, and I am just preserving that, and I am going into the conventional cellular area. So we open like a flap. The other advantage of flap is we excise and send it for histopathological degree of invasion, and the navigation is accurate before you remove the tumor. Once the tumor decompression is done, there will be a kind of displacement of structures, then navigation will become unreliable. So once we open the dura, then we do the conventional cellular decompression. This is the carotid area. Then I go lateral to the cavernous carotid artery and decompress the lateral part. And this was done under neuromonitoring. Then we handle this portion which is close to the carotid artery. We have to be careful, especially in old people, because too much of handling of carotid can displace some thrombus inside. These are the paracellular ligaments, medial wall of the cavernous sinus. This has to be cut, and then we go deeper and deeper. And at the end, you see that posterior compartment of the cavernous sinus, the inferior hypophyseal artery is coagulated and cut, and then further more aggressive resection laterally we can do. This is the carotid artery we can see here. This is the carotid artery. So at the end of surgery, and then we can go to the contralateral side and see. Because this part, when the diaphragm starts falling, it is very difficult to go into the cavernous sinus. You have to keep it compressed with a cottonoid. So I leave a little bit of tumor here till the end. Last, I try to remove this, because once the diaphragm falls, then it becomes difficult. So this is at the end of surgery. So carotid artery, sixth nerve was identified with neuromonitoring, and this is at the end. Sixth nerve was intact. This is the post-operative scan. So this is another case which I was showing previously. So this was a case of a growth hormone secreting tumor. Again, the philosophy was similar, but here the previous case in non-functional, we can stop at any point. We don't have to be aggressive. But in a functioning tumor, we are aggressive. In this case, after we have done the cellular part, I go lateral to this area, and this is the lateral cavernous sinus compartment. And we try to do as much tumor removal as possible, because the longevity is affected when you do a good aggressive resection, causing a decrease in growth hormone. See, this is at the end. Growth hormone from 29 has become 1.4, and 948 to 177 is the IGF-1 level. So these are other cases in which somebody had previously operated cellular, patient came with only cavernous sinus portion. So this is at the end of surgery. These are some of the other cases. This is the area where it goes into the place where third nerve enters the roof, and then it goes lateral to the lateral wall of the cavernous sinus. So this patient came with third nerve palsy. So we don't have to be too much, especially this area wherever there is a space is very limited. You can decide to stop. No need to be very aggressive. And whenever sometimes the cavernous sinus compartments, there are lots of loculations, and you open. Kind of every loculation can be opened, and then the tumor within that loculation should be taken it out. Sometimes it is like an open book kind of type, in which the tumor itself has opened up the corridor, and then you just go around the tumor, because there are not much loculations in this patient. This was a case of refractory prolactinoma, with patient had some kind of adverse drug reaction to the medication, so we had to do surgery. So this is where the third nerve enters the interdural space, and this is the roof of the cavernous sinus. This is the area of posterior clinoid, and then this is the sixth nerve lateral to the cavernous carotid artery. So this is the end. And this is another case. We do antero-inferior exploration when the tumor lifts the carotid artery and giving you a corridor antero-inferiorly. So this is the result of the growth hormone levels. So these are sometimes, along with cavernous sinus invasion, you have subarachnoid invasion. This is the worst kind of case, because any subarachnoid invasion, there will be lots of perforators involved. Like you can see, wherever there is a small lobule, here you can see that some perforator, so these kind of cases, we have to be extremely careful. Under vision with either 30 or 45 degree angled optics, you have to remove. We should not pull out the tumor. Here also you can see the ICA bifurcation is straddled by this tumor. It is all around. Lots of perforators are likely to be here. So this is at the end of surgery, almost a complete resection. So in this case, we left a little bit of tumor because the tumor consistency was not that favorable. Then we gave radiosurgery in this patient. And sometimes the tumor goes as lateral as to the kind of MCA bifurcation. This is also with subarachnoid invasion. So these cases also we have to be careful that we don't do any inadvertent kind of perforator injury. So whenever subarachnoid invasion is there, we have to be careful. Sometimes you can leave behind and give radiosurgery. So in a giant tumor, first we remove this part, then we remove the cavernous sinus part through the medial transcavernous approach, then we remove the supracellular part. But again, the risk always remains if something goes wrong with the transcavernous approach, you may have to leave behind. So that's why whenever we are only doing the medial transcavernous part, not the lateral transcavernous. Lateral transcavernous approach is done last. So video I'll skip. This is the end result of this patient. So this is way we deal with giant tumors with cavernous sinus invasion. So most of the time, the tumor consistency, if it is favorable and there is mostly you can have good outcome. So an evaluation of CT angiography and careful management becomes very vital. And anytime when the consistency is very firm, fibrous, or when there is a calcification, we routinely don't do a plain CT. But I have learned over these years that a plain CT, if it shows calcification, very rare actually in pituitary tumors, then also you can be a bit conservative rather than being aggressive. Because a calcified tumor can increase the complications. So in our NOS4 ICA encasement, we had this many cases, 31 non-functioning, 17 growth hormone secreting tumor. In non-functioning, we had 10 near total resection, 15 subtotal resection. And in growth hormone secreting tumors, we had 10 near total resection, 5 in remission, 2 medications, and 3 we gave gamma knife. And this is the end result. So aggressive lateral transcavernous resection is effective in expanded endonasal surgery for functioning tumors, and a conservative medial transcavernous decompression may be sufficient for non-functioning tumors. And even when we had failed to remove the tumor, but the mere attempt of a transcavernous resection by opening the dura and by doing a good bony decompression causes the compression on the neural structures to be better, and so that you can you get a more space, the tumor descends, you get more space, you can give radiation more effectively, especially when the tumor residual is small, you can give gamma knife. So a bony kind of exposure and the dural opening should be very good, and the tumor resection can be as maximal as safe and possible in our hands. Thank you.
Thank you, sir. I'll invite Dr. Ishita Pant ma'am for her lecture on recent advances on pituitary tumor pathologies.
First of all, I would like to extend my warm thanks to Dr. Jha, Dr. Jaskaran, and the entire organizing team for inviting me here. And now for the next 15 minutes, I shall be discussing the pathology of pituitary tumors with the recent updates. So I'll start with the cellular morphology of the pituitary gland, because the current WHO classification is totally based on the transcription factors and the cell types. So the anterior pituitary is made up of 6 types of hormone-producing cells, which have been categorized into PIT1 lineage, TPIT lineage, and SF1 lineage according to the transcription factor involved. While the posterior pituitary is made up of pituocytes, which are the modified glial cells, the non-myelinated axons of the neurons, and the stromal cells. And accordingly, I'll come to the classification later. The WHO 2022 classification has categorized the tumors of pituitary gland into anterior lobe tumors and posterior lobe tumors. The tumors of anterior lobe are the well-differentiated adenohypophyseal tumors, which we used to call them pituitary adenomas, but now the term PITNET has replaced pituitary adenoma. The second is a relatively new entity that has been added, pituitary blastoma and the craniopharyngiomas. While the posterior part of pituitary or posterior pituitary tumors are made up by pituocytoma, spindle cell oncocytoma, the granular cell tumor, and the sellar ependymoma. So for my talk today, I'll limit myself to PITNETs and pituitary blastoma, because the major changes have been introduced into these 2 categories of the tumors. I cannot say that the other categories do not have any other changes, but the changes are very minor one. So coming to the PITNETs, WHO has defined these tumors as a clonal neoplastic proliferation of anterior pituitary hormone-producing cells. They are by rule localized in the sellar region, often with suprasellar extension. They have a spectrum of clinical features. They may be an incidental finding, they may manifest with the excess hormone syndromes, or they may produce mass effects. Imaging has a very important role. It goes without saying that with imaging only we identify the sellar suprasellar mass. We can characterize its size, the optic chiasma compression, cavernous or sphenoid sinus invasion, and hemorrhage or cystic changes, if any. According to the recent report of Central Brain Tumor Registry of US, PITNETs account for around 16.5% of CNS tumors. So if we talk about the etiology of PITNETs, Risk factors related to exposure or lifestyle have not been definitely identified yet. However, there are many somatic mutations, some epigenetic alterations, some chromosomal alterations, and few specific germline mutations have been found which are associated with the PITNETs. Minority of tumors which show the specific germline mutations that are associated with known familial predisposition syndromes like MEN type 1, MEN type 4, neurofibromatosis, tuberous sclerosis, Lynch syndrome, and the list is a long one. So as a pathologist, what we get, we can have them as small pale nodules, or we can see large cohesive hyperemic masses with pushing borders. There may be variable extension into the suprasellar region. Invasion into the sphenoid and cavernous sinus is frequent. Duramater and bone invasion may be seen, and in cases of pituitary apoplexy, on gross appearance, we get the hemorrhagic necrosis. So as a pathologist, when we see at the slides, we see monomorphic cellular tumors which have diffuse arrangement, papillary arrangement, or trabecular patterns. The cells may be acidophilic, basophilic, or chromophobic with densely or sparsely granulated cytoplasm. The nuclei are usually bland with low mitotic activity. WHO has given us certain diagnostic criteria, and these are the essential criteria that the tumor to be labeled as PITNET, it has to be at cellar or suprasellar location with histological features which I have already described, and the subclassification has to be based on the immunoreactivity for transcription factors and the hormones. There are some desirable criteria which remain the old one. So before I come to the 2022 classification, let's have a quick look at the past classifications that I hope most of you must have heard or came across. The first classification was given by Hardy's in 1979, which has given 4 grades of pituitary adenomas, and it was based on the size of the tumor and the cellular disruption. Then in 1993, we had the NOSPS grading, which has divided the adenomas, pituitary adenomas, into 6 grades basically, and this was dependent upon the cavernous sinus invasion. Then in 2013, we have Traula's classification, which has divided the tumors into 5 grades, 1A, 1B, 2A, 2B, and 3, and this was based on the imaging findings, on the surgical findings, and the proliferation markers that are placed in a lab. After these classifications, we'll go to the WHO classifications that how pituitary adenoma has evolved to PITNET. So till date, we have 3 classifications, 3 WHO classifications for the pituitary tumors. In 2004, we had 3 entities: typical pituitary adenoma, atypical pituitary adenoma, and pituitary carcinoma, which all were based on the proliferation markers. Then in 2017, this typing was shifted, and it was based on the immunohistochemical expression of transcription factors and the anterior pituitary hormones. As a result, the term atypical pituitary adenoma was dropped down, and P53 as a proliferation marker was removed. But now in 2022, it has totally changed, and now we have to have the IHC expression of transcription factors, the pituitary hormones, and the assessment of low molecular weight keratins. And a new entity has been added, which I'll be discussing later, that is tumors with no distinct cell lineage. Pituitary adenoma, as I have said many times, that it has been, the term has been converted into PITNET, and the pituitary carcinoma has been replaced by the terminology of metastatic PITNET. This is just to show that how it has changed. As I have said, the terminology has changed, IHC has changed, and the types I have already shared. But the major reform has been done in this category of PIT1 lineage. Now it has 8 tumors, which are called the subtypes of the tumors. And this was the new entity I was talking about, the no distinct cell lineage, that comprises of two types of tumors, null cell tumor and plurihormonal tumor. Proliferation markers haven't been given any importance in the 2022 classification, and as I have said earlier, pituitary carcinoma term has been omitted. This is a complete WHO 2022 classification of PITNETs, and we can see that as a pathologist, when any surgical specimen of pituitary is being received in the lab, we have to describe the lineage, then the subtype of tumor, how this yields densely granulated and sparsely granulated somatotroph, same as for lectotroph and same as for corticotroph. So what is the importance of subtyping the tumors? It has an importance. Like for example, in somatotrophs, the densely granulated somatotroph tumor will definitely respond much better to the somatostatin analogs, while the sparsely granulated somatotroph won't. So this is how we can help in predicting the prognosis of certain PITNETs. Then we have to apply the panel of IHC for these transcription factors, for the hormones and the low molecular weight keratin, because the pattern of low molecular weight keratin has also been defined for almost all the lineages. This is something interesting in the new classification, that this classification states that histological typing and subtyping are more robust than any proliferation marker, and this only predicts the invasiveness to stratify the tumors. And basically, this classification has not given any grading or staging system for PITNETs. So the question comes into our mind that why there are so many changes? Because the pituitary adenoma was a term which was introduced in 1932, and it still features in the ICD and ICDO code. So what was the need? After long years of debates between different groups, the expert groups pointed out that not all adenomas are benign in nature. Some adenomas do show aggressiveness in their nature. Cells of the anterior pituitary are neuroendocrine cells, thus their neoplasm should be labeled as PITNET. Some PITNETs do invade, so they need to be considered as cancers rather than benign tumors, and this has started a big debate about whether the PITNET should be labeled as benign or malignant. But as of now, according to the WHO 2022 classifications, they have labeled PITNETs as cancerous lesions. And the expert group also said that a more accurate classification, they meant with the WHO 2022 classification, that this will lead to improved diagnosis and outcomes. So now as a pathologist, whenever we receive any surgical specimen, a pathologist's objective should be to confirm the diagnosis of a pituitary tumor, distinguishing it from other cellular-based lesions, to classify the type because it helps in the prognostication. And then the third point is to provide the prognostic information. And an ideal histopathological diagnosis should include the pituitary neuroendocrine tumor, its transcription factor, and the cell of origin. So this is an example of a report. Whenever I'll report any pituitary tumor in my lab, I should report it like a well-differentiated pituitary neuroendocrine tumor composed of PIT1 lineage adenohypophyseal cells with mamosomatotrope differentiation. And how this differentiation is given? It is provided on the basis of immunohistochemistry for the hormones. So I'll quickly go through the histopathology of various tumors, as can be seen here. The PIT1 lineage has 8 subtypes of tumors. So on H&E, the pathologist is able to see either it's sparsely granulated or densely granulated. Then, according to the tumor, we'll get the hormonal immunopositivity. For example, in somatotroph tumor, we'll get the immunopositivity for GH. In lectotroph for prolactin, and so on. But the common feature to all the PIT1 lineage pitnets will be a diffuse positivity for keratins, which is measured by the antibody CAM 5.2, and a strong nuclear positivity for PIT1. So a strong nuclear positivity for PIT1 immediately tells a pathologist that this tumor belongs to PIT1 lineage. This is the second category, that is T-PIT lineage pitnets, and again other features are same. The only identifying feature will be a strong nuclear positivity for T-PIT transcription factor. There is one more entity in this tumor, and that is a Krug cell tumor. The images are here. In Krug cell tumor, we get a pathological structure known as fibrous bodies, and these fibrous bodies are pale eosinophilic inclusions, and in more than 60 to 70% cells, we need to have these fibrous bodies, and the keratin expression is in the form of concentric laminations as seen here. This is the third category, that is SF1 lineage pitnets. Now gonadotroph tumors come under this lineage. In this, on histopathology, we can have a trabecular pattern, we can have pseudo-rosette formation, we can have the cells in diffuse sheets, and on hormonal immunohistochemistry, FSH and LH will be focally positive, while strong nuclear positivity for SF1 is diagnostic. This is the last category of the tumors, and that is pitnets with no defined cell lineage. It has two tumors, plurihormonal tumors, which are extremely rare. And in these tumors, there is a differentiation across more than one lineage. So it can express several combinations of hormones and corresponding transcription factors as shown here. You can have any combination. And then the last tumor is null cell tumor. Null cell tumor is a tumor which won't show differentiation towards any lineage or any hormone expression. So basically the panel will come negative for all the transcription factors and the hormones, and histopathology we'll see these type of cells which are chromophobic and arranged in diffuse sheets. So that finishes with the pitnets. Now there is another term which we all should be aware of, and that is aggressive pitnets. There are clinical and pathological criteria to define these aggressive pitnets, and these are 5 criteria. The first is a rapidly growing or a large size tumor. Then to show the invasiveness, out of these 3 we need to have one or more than one criteria. For high cell proliferation, these are the markers. We need to have 2 or more than 2 of them. Then the tumor will be refractory to the standard treatment, and you will see recurrence and rapid progression of the tumor. So out of these 5, we need to have at least 3 criteria to label it as aggressive pitnets. What is metastatic pitnet? Pituitary carcinoma, as I have already said, has been replaced by this term. This is very rare, and it forms 0.12% of the pituitary tumors and 0.4 to 0.5% of the pitnets. Lectotroph and corticotroph tumors are more prone to metastasize. This is another entity which all of us should be aware of, and that is non-functioning pitnets. They form 30% of all the pituitary tumors. They are usually benign. They do not have any typical clinical syndrome unlike the other pitnets, but they may produce hyperprolactinemia, sometimes secondary to pituitary stalk compression. Usually they are identified incidentally on imaging or from symptoms of mass effect. Often they have supra and paracellular extension, so that the total resection is not possible, and that leads to residual tumor regrowth and recurrence. Novel prognostic biomarkers for non-functioning pitnets are the need of the hour. Why? Because for the functional pitnets, we do have biomarkers, and if we keep on monitoring those biomarkers, you will detect the recurrence in functional pitnets in a timely manner, and so that you can go ahead with your management. But unfortunately for non-functioning pitnets, we do not have any such biomarkers. So that leads to a delayed identification and suboptimal management. This is my favorite table as a pathologist, because if in my lab I have a panel of IHC for these 5 transcription factors, The WHO 2022 classification, which is the latest classification, is based only on these markers. If I have all of these markers in my lab, I can diagnose all the pituitary, the pit nets, the metastatic pit nets, and the aggressive pit nets by these markers. All this depends upon the lineage. As I have said so many times, a pathologist can identify the lineage based on the transcription factor. Then you have to correlate the other hormonal expressions. And a very important thing is the staining pattern of the low molecular weight cytokeratin. That gives us the diagnosis for all subtypes of the pituitary tumors. How to prognosticate? There are some features that indicates towards a negative prognostic impact. For example, out of many, these 5, that is the sparsely granulated somatotroph, silent corticotroph, immature PIT1 lineage, Krug cell, and the acidophilic stem cell pit nets, they have a poor prognosis. Tumor invasion and cell proliferation, of course, they have a poor prognosis. And then certain somatic mutation, as listed here, germline mutations and epigenetic alterations are associated with poor prognosis. I'll just touch pituitary blastoma since it's a newly added entity. It's very rare. There are only few case reports till date in the literature. They occur exclusively in children less than 2 years of age. Clinical presentation usually is due to pressure symptoms or because of Cushing's disease-like presentation. It is caused by mutation in DICER1 gene, which is a part of this gene-related syndrome. On histopathology, we can see rosette formation that resembles the immature Rathke's epithelium. Then we can see small cells with blastema-like appearance and large secretory epithelial cells on histopathology. Majority of these tumors express ACTH and only a few express growth hormone. So how should an ideal pituitary tumor multidisciplinary team should look like? This is shown here. Of course, the neurosurgeons and the endocrinologists are at the core of the team, but the team should also have some radiologists, pathologists, ophthalmologist, the ENT surgeons, the radiation oncologist, and of course the dedicated nursing staff. There have been many articles. I have shown one article here. They have proved that how beneficial the multidisciplinary approach, they have proved the importance of the multidisciplinary approach in their cases. So to conclude, does this new nomenclature offers an extra edge to the neurosurgeons for its management? Any guesses? All neurosurgeons are here. So unfortunately, the answer is no. Although this classification, this nomenclature, which has been, which has evolved after so many debates, it gives a deeper insight into the histological picture. But for neurosurgeons, it only offers something for their follow-up strategy and post-surgery management. It does not add anything in their decision-making, and especially when they are deciding the plan of action for surgery. So what is required next? A comprehensive, integrated neuroradiological-based classification with more emphasis on the invasiveness of these tumors, which is needed for the neurosurgeons so that it helps them in planning the treatment strategy and the further management. Thank you. And as per my communication with Dr. Jaskaran, I tried to make it as simple as possible for the neurosurgeons. So I hope it was not too much. Thank you.
Thank you, ma'am. Next, I'll call Dr. Daniel Prevedelo, sir, for his lecture on prevention and management of IC injuries in endoscopic approaches.
Thanks so much. Once again, really appreciate you guys inviting me to come here, and hopefully I will not fall asleep with my jet lag. I really appreciate the previous lecture, particularly on the last slide. I thought the conclusion will be that from the pathologist that this classification helped us, and I have to agree that it doesn't help. And one thing I would add, we didn't change. We still call pituitary adenoma, like we can't resist. We still say pituitary adenoma. Like I don't think we will ever change. So now. Dr. Gozal asked me to present a little bit of carotid, so I apologize if this will be a little too much. But I think it's very important that we see some of these disasters and trying to understand, how to avoid and what to do in an emergency as well. So the key points, I think this is the most important slide, is like if there is a disaster, like how to avoid a disaster. So really knowing anatomy is definitely, like we did it today, spend the entire day dissecting. That's the main way to avoid these carotid ruptures. Also having proper technology. I have one carotid that I have the problem because the drill was not the one that was typically using. The drill was too aggressive. The drill bit was too aggressive with the spikes of diamond too aggressive. So understanding your technology and using properly is very important. Then the next is visualization. Because sometimes you have good equipment, you know anatomy, but if you cannot see the anatomy, you're going to have problems. So really have good exposure. So working with the ENT, or if you work by yourself, make sure that you have good exposure, really like so you can see to avoid problems. Then microsurgical technique, using both hands, very important, right? Because you don't want to do like earlier in this endoscopic and nasal surgery 20 years ago, and started like ENTs were working with only one hand, holding the endoscope, and only one hand doing dissection. So it's very important. That's what you saw, like, we had help at the DUSIC today, like really, so I can have my two hands there using my suction in left hand, and then the drill on the other hand, the dissection on the other hand. So like microsurgical technique when you go to the intradural space, very, very important. Then reconstruction on these cases where we have a major leakage, exposure of the brain and spinal fluid, to avoid complications in general, and also to protect the carotid artery. So sometimes if you have carotid artery exposed, it's better to cover it up. I have one complication early in my career where we operate on this malignancy, expose the carotid artery, and then 2 months later, the patient had a rupture of the carotid because it desiccated it. We didn't cover up. And then we learned like how important it is to cover the carotid every time as well, because you don't want to have that exposed to the world, particularly patients that will have radiation. So you leave the carotid exposed, then you give radiation in the back of the nose. You need to cover it up as well. Working as a team, I think it's extremely important. The fact that we saw that graphic at the end with all the teams, very, very important. Work with all different specialties is very important. ENT in the operating room, I think, is key. And then the care on the post-operative care, perioperative, very important. So here's the analogy that I love. This the Greek Egyptian Ra, which is the sun, it looks like the pituitary gland, and the carotid arteries are the cobras. The cobras. You gotta respect the cobra. I'm not gonna show this crazy video here. The Dr. Janakarian showed it to me, but this is like showing that you gotta respect the cobra. You need to learn the technique, how to manipulate the cobra. And like what we are dealing today, like drilling, making it very thin, and then elevating the bone away from the carotid artery is very important, because you don't want to disrespect the cobras, and it may bite you. It may be problematic. You need to have a technique like this guy. Look at the technique. This is it's interesting. So if you look at how he has his technique with his head, and respect the cobra, and dominate. So you need to know the anatomy. I think that's the whole message here, and be able to avoid problems. So the most important is really like respect and knowing the anatomy. So just quickly here, what we did the entire day today is an example of understanding the anatomy, and then we can replicate that in the operating room. This is just an example here, working on the supraclavial area, the superior corridor to the interpeduncular fossa, and here's like in the real life. Here's in between the carotid arteries, between the sixth nerve, transclavial, and this is a meningioma. We took it out from there. And then from magnum down here, and that's the same. So everything you dissect in the laboratory, it's going to be like be more familiar. So in the operating room allows you to avoid this type of problem. So here's like showing the carotid artery coming here, the lacerum. We dissect this so many times today, every station. And then you have the paraclavial and the paracellar carotid artery going intracranially there. So knowing this anatomy is very important. These are the sympathetic fibers we dissected today. As you can see, they jump from around the carotid, go to the sixth nerve, and you have this paraclavial carotid artery, paracellar, which is the then paraclinoid. This is the picture that I think summarizes. I think Dr. Gozal showed one earlier today. I'm not going to go here through the whole anatomy again, but just to remember the parts of the carotid artery, the parapharyngeal carotid artery, in my opinion, is the most vulnerable because there's no bone landmark around. And as we heard the talk today as well, it can sometimes be dolic and comes more superficially in the nasopharynx. So you got to be very careful when you do dissection in the infratemporal fossa because of the parapharyngeal carotid artery. Enters the bone at the petrous level, has a little bit of a vertical segment inside the petrous bone because after becomes then the horizontal petrous bone or petrous carotid artery there, then lacerum foramen, and then you have the paraclavial. And at the level of this area here, it enters into the cavernous sinus per se, but that's what we call the paracellar carotid artery, all the way to the distal ring. And then this segment between the distal ring and the proximal ring here is the paraclinoid segment of the carotid artery. And this is the area that is vulnerable as well because the bone may be dehiscent in that area. So we'll see areas, situations that can be a problem. And this area of the carotid artery in between the proximal ring and distal ring, this is what it forms between the periosteum and the carotid artery itself. It forms the cavum, the carotid cave. Where the takeoff of the inferior hypophyseal artery, superior hypophyseal artery can come from there as well. And also the ophthalmic artery can go around here to go to the optic canal. So all these are vulnerable areas. We need to know the segments, dissect in the lab. And I think that's the most important message in terms of avoiding, is really knowing their anatomy. Now I'm going to show some videos here. Most of these are gifts, like people that donated this for education. So I'm not going to say names or where they come from, but the idea is to learn with their mistakes of the other surgeons. So this is some of a little rough technique, as you can see here, like drilling the soft tissue. So I'll put a little pause. So most of these videos are a combination, but I try to classify them as like a technical mistake or lack of anatomy. I think in this case, there was really a problem with anatomy as the surgeon was being rough as well. But you can see here that if I put another pause here, you can see this is the carotid artery turning in the back of the orbital apex here. So you see that the problem with the instrumentation. See, look at the size of the scissors that the surgeon is bringing here. It's like regular scissors trying to dissect the last piece of this was nasoangiofibroma, so real problematical when you get this type of problems. And then here, like one of the ways to control, we're going to talk more, is really using muscle to it provokes the cascade of coagulation and helps to stop the bleeding. I would not recommend bipolaring. I think that every time you try to bipolar, you make the hole bigger. If it is a little branch, perhaps, but they also, like we talk about FlowSeal today for venous bleeding, but never inject FlowSeal into arterial segment. The patient will now wake up. It's going to go and it's going to embolize the entire arterial system. So don't put it inside. But the use of compression and the use of muscle is very helpful. Now, this is my favorite video because it shows other problems here as well. So this was a small pituitary adenoma, and you can see here, in this case, it's a problem related to the anatomy as well. So the surgeon is exposing, again, lack of exposure is one of the issues here. And if you look at here, the sella is down there, but the surgeon decided to expose the carotid artery. And as you can see here, it covered the normal anatomy with this half by half, so it got disoriented. So don't cover much, is very important. So now you can see here the anatomy. See, the sella is down here, and the surgeon exposed here. See the carotid, see the optic is right there, optic carotid recess, just for orientation. But this surgeon was thinking that this was the sella because he covered up and got disoriented. See, oh yeah, it's a little interesting sella, but let's open, let's get the tumor out. And decided to open right there. And then it's interesting, it was bleeding, but it continued. And I've seen the report of a surgery like this, and then the surgeon goes like, well, image guidance is not accurate, so that's why we kind of went there. But so you cannot justify and blame on equipment. You need to know your anatomy. And this is so fascinating because, see, it's really, I'm going to put it again, because you look at here, the carotid is there. It's very, after you dissect it today, you can clearly see that that is just there. But see, when the surgeon covered it up, it became, you can make it look like a sella, you know? So, but it's quite incredible. And this is, I wouldn't say famous surgeon, but it's someone you know. Sometimes you can get disoriented, yeah. So technique, in terms of like the right way to do, we talked about this in the lab today. So drill until it's very thin, and then you can experiment. It's too heavy, so if it's heavy, you drill a little more. Then you drill more until you can elevate that bone away from the carotid artery safely. So I think that's a very important technique. You saw me doing the lab there, so here it becomes obvious. See, this is a middle clinoid, and you can see the entire siphon of the carotid artery being exposed with this technique. So make it very thin, carefully with a diamond drill, and then you can elevate it away. So in terms of technique issues, so this group, very famous group, here, the problem is that decided to remove bone after the dura is already open. And they start taking this bone in the paraclival area, forcing in the direction of the carotid artery. And then this is what happens very fast. You got into the carotid. Now the dura is open, so you have two problems here. Now the carotid is bleeding, but also the blood is going intracranially. So this group is very, very good. So they were able to, ENT and neurosurgeon working together, they were able to keep the suction in position, and eventually they were able to control this bleeding by putting Surgicel and muscle. And they were able to get out of there. This patient apparently did very well with no problems. And here's another one showing lack of exposure. As you can see, only one hand, you will see this surgeon is famous, working only one hand, didn't remove the mucosa before taking the bone, decided to monopolar the opening, is using only one hand to kind of crack things around, and didn't have a good exposure, and forced that in the direction of the carotid. So bluntly got into the carotid artery by forcing in the direction. So never forces in the direction of the carotid. I tell all my residents and fellows, I always kind of, if you want to use a caudal there, like you push it down, always away from the carotid artery, never in that direction, because this can happen. This is a famous neurosurgeon. And I don't know why, like it was, you know, use this technique, but the surgeon was kind enough to share with us, you know, like, and then the question is what to do next, all those questions, but we're going to talk a little bit about that later. This surgeon was able to control, try to put some flow seal around it. Again, you cannot inject, but then they just packed, and apparently this patient did well as well. Here's another one that people are afraid of this video because you can see lack of exposure, septations are still very thick, and exposing only one hand, see no drilling, forcing too much, but then decided to come with the Kerrison. Look at that, look at the anatomy or where the bite was right there. So people think about coming with the Kerrison, you're gonna be on the epidural space. The problem is that the carotid right there is in more anterior, so you can actually grab the carotid. And so just by using Kerrison doesn't mean you're gonna avoid this problem. And they were able to control with this balloon. Here's one of my own. This is my own situation here. This was a meningioma on the other side. And this was crazy because I was running 2 rooms and I was doing a pituitary in one room. I came to the room, exposed this side. The tumor was right there. And we didn't expose the right side of the nose because I thought we're gonna just go there. But I was in the other room and my fellow decided to open a little further on the right. And although we're dealing with a decompression on the meningioma on that area, on the left optic nerve, decided to drill blindly here. I don't understand up to these days why it came here. And it drew into the carotid artery. The problem now is I'm in the other room and this nurse comes like, Dr. Pravanella, Dr. Pravanella. And I run the 2 rooms looking, I have the imaging of the other room. So when I look at the imaging there, I saw this. I was like, oh my God. And then I had to run to the other room. And in one point here, it's me. I don't know in what point I got there. But here on this thing, what we were able to basically put muscle. I put muscle and I kept the muscle in contact directly there. So muscle works, but don't think it works very fast. You need to keep the muscle there and wait until the point where there's no more bleeding. We did an angiogram for this lady and there was actually no pseudoaneurysm. So we did several angiograms until the day that we decided to go back. This is, I think, when we went back a few days later. And we were able to carefully bring that plagets down, and the muscle was in position. It worked very well. So no more bleeding. This is second surgery after elevating everything. And then eventually I took it, 6 months later, I actually brought her back, did a craniotomy to get the meningioma out. I decided not to go through the nose again. But it was just muscle, and we did several angiograms and then CTAs. She never developed any pseudoaneurysm, this one. So in terms of, let me just pause here and tell you, like in terms of things to do, let me just show you this other one related to technology. So this is venous plexus bleeding. This is the one that works very well with Flosil or Spongostan or the other brands, but this is the way for venous works very well. But don't do this as if the blood is arterial. Use of Doppler, very important to identify the position of the carotid arteries. ICG helps you to localize the carotid artery as well, something that we use when we need it. And here's what I will show you, like that I mentioned earlier, like I used this drill bit that was very aggressive, and this is what got into the carotid artery. So the larger than 4.5 millimeters, they tend to be so big of a diamond that when you spin, you only see the core, and you're actually reaching further away. And this is what happened on this case here. I was drilling the clival area there with this more aggressive drill and got into the carotid paraclival with the drill. This case, we actually, when we did an angiogram afterwards, the patient did have a pseudoaneurysm. So we have to reconstruct the carotids by using muscle through the nose, and we put 2 stents into the carotid artery there. So the bottom line, I think, in terms of what to do for reconstruction, you always have 3 options. This is using ultrasonic device. The company may tell you that nothing happens, but you can also have a carotid rupture with those. So I would say that, just to stop here for a second, but the 3 options you have once you have a carotid, like first of all, I do think it should be done in an environment where you have angiogram endovascular team ready to go if you're doing high level complexity. The options are going to be either you take the carotid down with like sacrificing, either in the operating room, or you sacrifice it with the coiling or using endovascular technique to sacrifice the carotid. I think that's usually a safe way to get out of there. If there's no pseudoaneurysm, like that case that I showed, you have the option of just wait, repeat multiple angiograms, make sure pseudoaneurysm doesn't form later on. And the option number 3 is if there's a pseudoaneurysm, you do need to have something inside that carotid artery. That's when a stent then becomes an option. The problem with the stent is that you do need to coagulate the patient, need to use antiplatelet system, and becomes more like an issue if you need to go back with surgery, things like that. But those are usually the 3. Either you sacrifice or you reconstruct with muscle from the outside and stents on the inside, or if you have a situation where your team can put a cover stent is an option as well. And the other options, if you don't ever form a pseudoaneurysm, you can just observe. Let me show you this, which is very impressive. A friend of mine from Argentina showed me this case. So when you see a dark T2, and you think it's an adenoma, you have to pause every time, because they actually even did a MRA, and MRA was normal, but during surgery here, they were taking this pituitary adenoma, they thought, but they were actually inside an aneurysm. So basically, once they enter into the cella, it was just taking the clots of an aneurysm, basically then he had to repack, and the patient apparently did fine, but you don't want to be in that situation. So just pay attention if dark T2, you may actually be dealing with an aneurysm. This is post-op, and they did fine. Just to go to finalize this, one of the things we do have in our course is actually a model to practice how to control the bleeding as well. So there's several models out there that pumps through the carotid artery of cadavers, but we have this 3D printed here. This is Rick showing our model. Every course we have a station where the participants came and practice how to control the bleeding. So we have a pressure pump through a 3D printed head to simulate. This course, I don't know if Dr. P.J. Warmold is still doing in Adelaide, but he used to do this course before COVID, or where you can practice on a biological model, where you have the sheep neck with a carotid in the back, and he did a lot of research with that. The only problem is not anatomical. This is a real artery, a carotid artery of the neck of a sheep, but you can simulate there to practice also to control. So here you kind of expose, then they would put clamps on the carotid of the sheep, the animal that is dissected under anesthesia, and then put a clamp before and after, and you can do a cut on that carotid artery, and then you open the clamps on the carotid of the sheep, and then boom, now you have to control. So it's an interesting model because it's biological, right? There's a real factors here going on. And he's the first one that published really consistently that using the muscle works in these cases. So here's I learned a lot from him. That's what I think is the best technique, is to use the muscle. You kind of have to hit the muscle to release some of the factors, and you keep it in position, and then once you release, it's great. Of course, it's not going to work if you transect the carotid side to side like all the walls, but for cuts, small cuts, it would work fine. And you got to keep a pressure for several minutes, if not up to 30 minutes. So this is my last slide, just to bring up some important aspects as well. So having 2 suctions, very important. Remember that whatever you touch, the bleeding is going to go in that direction. So if you put 2 suctions through the left nostril and you camera on the right nostril, so then the bicapillarity, the blood is going to follow the position of the suctions. And if you keep a suction on the same side of the camera, blood is going to come on the camera. So it's a very, very quick thing to do, and just move your suctions to the other side and then keep the camera by itself. So then you can actually more likely keep a visualization. The other thing that use cotton for compression, as I said, get the muscle plug very fast, keep blood pressure high, normal. Don't try to bring it down because you want to perfuse the brain. The other thing that is not intuitive is heparin. You want a 5,000 heparin like immediately because you don't want to, because you cut the carotid. This is very, very strong on the ENT literature for neck dissections. When they get into the carotid, it's very solid in their literature. The fact if you use heparin, you have less stroke potential afterwards. So you want to use heparin, although you're trying to stop the bleeding, so people forget about that. But it's very important to decrease the amount of a stroke showering into the brain. And get blood, and also have like some people like in California, Garney, they have with Dan Kelly, they have actually a timeout for hemorrhage. Like they time out, like if we have a hemorrhage here, we have blood, we have this is what we're going to do. So this is very, very important as well. And for those interested and participate in our model for carotid as well, we have our next course May 29 in Columbus, Ohio. Thank you so much.
Thank you, sir.
Rectus abdominalis there. And he went there and he was sweaty. And I said, what's going on? And he goes like, I cannot find any muscle. The old lady doesn't have muscle. She doesn't do sit-ups. I was like, oh my God. And it's true. I went there. We were in the space of the muscle and there were just little, you could see the muscle, but there was almost nothing. So we abandoned to try to get muscle in the belly. Now we always prep it tight. The quadriceps is in 3 seconds, you have a big cube. And that's what we do then. Oh, and that's another thing. You don't want it too small because the gus comes in the suction. You want a little bigger cube. So then it's easier to manipulate in the middle of the disaster because you got to push through the blood and put it on the mouth of the thing. So you want a nice, at least 1 per 1 centimeter cube that is not going to disappear into your suction.
Lateral part of tongue can be cut and it can be kept. Tongue is also a muscle. When we are not getting any muscle, lateral part of tongue can be cut and it...
So, in your experience, have you ever...
I keep going. Then I open the craniotomy. I do one immediately after the other on the same anesthesia. But I've seen, I think, a group in India, they're doing at the same time endonasal and craniotomy. I think is a great idea.
Anytime you use any relaxing skin incisions for your expanded approach, any relaxing nasal incisions or a palatine or a mucosal relaxing incision?
I guess the answer is no. We don't. You're talking about incision on the face? Oh no, we don't use any. No. Yeah, maybe for large like a juvenile angiofibromas, maybe sublabial combined like a caudal luck. That we do, but not in the skin. I've done that a couple times for carcinomas that are very intimate, invading around the carotid artery, particularly the parapharyngeal carotid artery. We've done this technique that Dr. Mario Sana, he does a lot of that in Italy. I learned from him. We start putting stents on the carotid a month before or 2 months before. Depending on the endovascular person, will ask you for more time on the antiplatelet, because the risk is if you stop too early, then you may thrombose everything. But we did not too long ago, me and Corral, we put it on the parapharyngeal, and then we actually combine endonasal and open, and I dissected from the carotid with the knife. Like, and you could see the metal, like it works. It works. Then you see the stent at the end of a resection. You almost like you take some, not in the entire thing, but when you're more aggressive, you see it. Yeah, it works, but I think it's something you got to be careful. Yeah.
Along with the tumor, I mean, we had 2 cases like an angiography, there's a pituitary tumor you're trying to operate upon, and there is already an aneurysm in the cavernous ICA. Do you encounter it?
I don't think I had that situation. I had cases that the clip was already there, that I saw the clip, but never, I don't think I had one that I had to plan with the.
If at all you had it, then what you'll do? Because if you look
I think you
at
gotta
FD,
take
then
care,
you'll have
take
to
care
give
of the aneurysm first. Yeah, I think.
but
Because
then
you
you'll
don't
have to
wanna-
give antiplatelets. That
Then you do a craniotomy, clip it, or endovascular, and will depend on the aneurysm. But I think you gotta plan to take care at least even if it is in the same surgery, I would do the aneurysm first, and then take my time taking the tumor afterwards.
I agree with you that we need to repeat angiograms because 2 cases we had, and there was no pseudoaneurysm on the first angiogram, but on 5th day, we repeated an angiogram and there was a
Appears afterwards.
pseudoaneurysm
yeah.
was there.
Or carotid accidents.
And
yeah.
and we did a mistake that they did the coiling only. But on 7th post-op day, there was again an epistaxis, and the coil had prolapsed into the nose.
Oh, yeah, that I had.
So
that-
it has to be
myself.
stent-assisted coiling. I mean, that's
Yeah.
Thank you.
Crush the muscle and push the muscle. Yeah. And what did you say?
I think we can go ahead with the next lecture and we can discuss these things at dinner or tomorrow, because Dr. Dusi has also to say after this.
Sounds good.
Okay, your all questions will be taken care of. I think he will take care of those questions later. Thank you.
So, very good evening. And thank you, Jashkaran, for this wonderful opportunity. I'm sorry, this is the last minute replacement for my mentor, Dr. Ramandeep Redke. He is not unable to make it today. And thanks, Danny. Almost, he said 9 times ENT team during your presentations. So, whenever I hear the ENT from the neurosurgeons, I feel proud and it gives us goosebumps. Thank you, Danny. So, today's my presentation is on the reconstruction of the skull base. So I'm not talking about how we reconstruct. Okay, I'm going to discuss about how we harvest the hadad, tips of the hadad, and how we are utilizing the hadad. Because that reconstruction techniques is individualized, so it depends on the surgeon. So whenever you are able to give the 100%, more than 90% at least success rate, you just follow the techniques. So the techniques doesn't matter. So, but I'm going to discuss only about the flaps, how we harvest, and the tips. So the skull-based defects usually happens due to the trauma, iatrogenic, or sometimes it's due to the non-traumatic causes like radiotherapy, infections, and congenital or spontaneous CSF leaks. So the skull-based defects, how we are get either in the sagittal corridor from the frontal, claviform, planum, cellular, or the clival defects. In the coronal sections, you will get the orbital or supraorbital pathologies from the middle cranial Peter suffix pathologies and the posterior base pathologies. So the techniques, again, I told you, usually we use the multi-layer techniques. Again, someone prefer the solid reconstruction, some may not. So, but always we go for the multi-layer closures. Usually we use the fascia, fat, and the, in a high flow leaks, we will go for the hadad flaps. So it's a multi-layer. Multi-layer is the key to success in a high flow CSF leak. So how to decide when to go for the flaps? So it's mainly depends on the what type of size of the leak, the location of the leak, and the grade of the CSF leak, and that is the history of previous radiation, and there is history of previous surgery, and of course the experience of surgeries, experience of the surgeons matters. So some simple basics of the flaps. The septal flaps usually based on the spinopatine branch of the maxillary artery, and the lateral nasal wall flaps usually based on the anteriormost flaps are based on the anterior artery, and the posterior lateral wall flaps are based on the spinopatine and its branches. So that non-vascularized grafts like fat, fascia, they usually taken by the imbibitions and inosculations, revascularization and neovascularization process. But in vascularized flaps, they will go, depends on the perfusion of the wound site and the various stages of inflammation. They go through the various stages of inflammation and neoangiogenesis and then final remodeling. So the most common local flap, I'm going to discuss only about the local flap. The most common flap is the nasoseptal flaps and the middle terminate flaps, and sometimes we also go for a inferior terminate flap, and very rarely we use the anteriorly based lateral nasal flaps. So whenever you hear about the nasoseptal flaps, remember these lesions. They are the one they made these anterior skull base surgery, safer. The Haddad one, that is called Haddad vasogastric flap, that is what we routinely use in nasoseptal flap. The second Haddad 2 flap, that is designed by the Karu, that is the anterior based lateral nasal flaps, and then sometimes we can also use for the middle terminate as well as the inferior terminate flaps. So the some basics for the Haddad flap. You can see that this is a sphenopalatine artery, this is a nasoseptal branch, and this is a nasoseptal branch. This is not a single branch. Sometimes it has a multiple branches. It goes, but always located between the ostium and the roof of the choana, right? So, but it is not a single branch. It may have the multiple branches. So, what are the keys to the while making an incision? Remember, when you make a incision, start with the inferior incision first. Why? Because if you make a superior incision, sometimes we may cut the artery, it will bleed the field, it will compromise your visuality of the visions of the inferior part. So always start the inferior part of the inferior incision first, start at the roof of the choana. And when you make an incision, make sure that you are going to the bone deep. So it makes your flap elevation easy. So okay, so start from the roof of the choana and comes down. So okay, how to make this incision? Whether go along the posterior septal wall or you take the turn. So it depends on the where you are area of the target. Suppose if you are dealing with the sella, tuberculum, planum or cribriform, you don't need a much thickness here, right? So you can take the angulated cut and make the wider at the anteriormost flap. Similarly, when you take the superior cut, you take the superior cut at the level of ostia and come to the midpoint of the middle terminate. Never go to the axilla because it increases the width of the pedicle. If pedicle is too large, it occupies the more space here and the rotation also difficult. But when you deal with the clivus or cavernous area, we need a wider base. So in that case, we go for a more posterior vertical incision, and also this superior incision goes till the level of axilla. Never crosses the axilla. It will compromise the olfactory functions. So these two landmarks are very, very important. This point is learned from my guru, Dr. Vicks. That's why it's called as a Vicks point. So the another important thing is about this midpoint and the middle terminate. When you see the sphenoid ostium and the midpoint of the middle terminate, they are in a single line. So what the literature says, we have to preserve the olfactory functions, we have to stay 1.5 to 2 centimeters below. But it is difficult to measure how far we are away from the skull base. So one landmark that is safer landmark is the midpoint or middle terminate or the axilla. So never go above the axilla. So there are different types of Haddad flaps. This is a small Haddad flap where the anteriormost incision is not at the mucocutaneous junction, it's just far away from the mucocutaneous junctions, where it's usually used for the small meningoencephalocele, especially the lateral recess leaks. And this is the classical Haddad flap. The type 3 is the extended Haddad flap, where we can use for the cribriform defect, or sometimes we go for the frontal defects also. So these are the areas where we are usually using the Haddad flaps. So this is how I harvest the Haddad flap. It is the right side nasal cavity. You can see there is a ostium, and I start at the roof of the choana, and I use the monopolar always at the 12 to 15 volts settings, and go to the floor of the nose, and then comes till at the level of mucocutaneous junctions, and make sure that when you make an incision, it's going to the cartilage or bony tip. And this is the ostium. And once you make the incision, always go slightly laterally. It will go the better rotation. Okay, this is a slight lateral incision. So, and I follow the ostium and the midpoint of the middle terminate. I just do that vertical incisions. So I am 100% sure that olfactory mucosa was preserved. Okay, so then the superior incision. Another difficult area was the more superior incision. How we follow that? So I never make a superior incision from the nasal cavity. I elevate the flap, go inside the flap, and free the flap till the posterior edge, right? So from inside the flap, I got the dorsum of the septum, dorsum of the nose. From the inside, it is safer, and go inside the flap. By doing this way, I found it safer, as well as I get the maximum width of the flap, because it's most of the time it's very difficult to reach this area with routinely. So then once I elevate it, then I dissect the flap, follow the subpericondral planes, and then we house it in the, routinely we house it in the nasopharynx. So what is the drawback of placing the Hadad inside the nasopharynx? So it goes for the venous congestion. I'll show in the coming slides how it looks. Okay, so this is but routinely what we follow, we place it in the nasopharynx. So but what is the safest way? So this is the case of nasopharyngeal carcinoma, adenocystic carcinoma, where I harvested the flap and I made the opposite side maxillary antrostomy. And once I harvested the flap and I dissected away from the sphenoidal wall, and then I place it inside the maxillary sinus. By doing this way, I can get the working area in the nasopharynx, as well as I will maintain the vascularity of the flap, and there is no congestion, venous congestion, right? So this is the flap, and also I was dissecting from the anterior wall of the sphenoid for the better rotation and the better get the good working area, and then I place it completely inside the widened maxillary sinus. I will show how the flaps looks in the coming slides. So where all we are using this Hadad flap? The common areas are sella, planum, cribriform areas, cavernous sinus, petroclival areas, and then infratemporal fossa and the middle cranial fossa defects. So this is the case of pituitary, recurrent pituitary adenoma. So where we had a grade 3 CSF leak. So once we harvested, we put the fasciolata on underlay technique, and then followed by layer of fat, and then we obliterate the clival recess for the better take up. So see the color of the Hadad, it was blue. This is because of the venous congestions. Hope you are all appreciating this one, but this is one of the reasons that says that it goes for the necrosis, but we never encountered any vascular necrosis. So this is the way, so we reconstruct the cellular defect using the Hadad flap. This is the case of planum meningioma. So you can see this planum was completely exposed, and then dural incision was made, and then tumor was removed. Once after the tumor removal, we place a layer of fasciolata on underlay technique first, and then a small piece of fat followed by the overlay fasciolata, and then we supported with the Hadad. Again, you can see the blue color. There is a change in the color. This is again because of the venous congestion. So this is the case of sinonasal adenocarcinoma with right side cribriform involvement. So the left side cribriform, this is a modified draft 3 procedure. This is a normal cribriform. This is a right side cribriform defect, where we use again the same multi-layer fasciolata, and then the extended Hadad was used in this case to cover the cribriform defect. So this is a case of cavernous 6-nerve schwannoma. I'm not going to show the video. So you can see that since we are discussing about the transpterygoid, we use the transpterygoid approach in this case. You can see the cella, this is a cavernous sinus, this is a V2, this is a VDN, and this is a paraclavial carotid. The tumor was completely removed. So since we are used the transpterygoid approach, the pedicle was compromised. So I harvested the Hadad from the other side to cover the carotid. So this is very, very important because we are the carotid was exposed. It has to be covered with the vascularized flap. So we harvested opposite side Hadad, and it is covered. This is a case of adenocystic carcinoma of the nasopharynx. Again, here also, this is a nasopharyngeal adenocystic carcinoma on the left side, I'm sorry. So this is a nasopharynx. This is after tumor removal. You can see the prevertebral muscles. This is a pterygoid muscles. This is a middle pterygoid. This is a eustachian tube, and this is the parapharyngeal fat. So this is where the parapharyngeal carotid lies. So we need to cover the area with a vascularized flap. So this is the flap harvested from the other side. It was stored from the maxillary sinus, and see the color of the flap. There is no change in the color. It was pinkish. So there is no venous congestion which will happen when you store it in the maxillary sinus. So this is a case of V3 schwannoma, where transpterygoid approaches again we used. This is a V2. This is the pterygoid body. This is the infratemporal fossa. This is a nasopharynx on the right side. You can see the V2, VDN, sphenoid sinus, the pterygoid body, lateral pterygoid plate, and the greater ring of the sphenoid. And once the pterygoid body was drilled out, we followed the VDN, but the tumor was within the infratemporal fossa was completely exposed, and we drilled out the greater ring of the sphenoid, and we can see the widened foramen ovale. You can see the V2 that was intact, the middle fossa dura, and the paraclavial ICA. The extracranial portion was removed, and this is the intracranial extradural portion part was removed. And then this is the exposed paraclavial, exposed horizontal segment of the petrous. So, and even though we didn't encounter the CSF leak in this case, but since the carotid was exposed, we used the opposite side Haddad flap in this case. And this is the case of, again, the petrous chondrosarcoma. Again, you can see the complete transpterygoid approach was used. You can see the cavernous sinus, V2, paraclavial portion. This is the paraclavial portion, this is the laceral portion. And you can see how we use the VDN as a landmark to get the foramen laceral segment. And this is a petrous segment area, petrous apex area. And you can see that the horizontal segments completely exposed. And again, we use the opposite side Haddad. But it doesn't mean that whenever you use the transpterygoid approach, we always go for opposite side Haddad. Sometimes, especially non-malignant cases, we can use the same side Haddad by means of transposing the sphenopalatine artery. So this is a case of type 3 lateral recess leak with less pneumatization. So I need to sacrifice the VDN in this case. So this is a type 3 leak. So you can see that this is a pterygopalatine fossa that was mobilized. And in this case, I use this very small Haddad. And then, so when you transpose the sphenopalatine artery, make sure that your incision is extending lateral along the lateral wall. That is very, very important. And this is a palatovaginal canal. So this is a palatovaginal canal that was cut. And then once you cut, you encounter the VDN now. The VDN also sacrificed in this case, and then pterygoid body was exposed here. This is a pterygoid body, and then the whole sphenopalatine artery along with the flap, it was transposed into the maxillary artery. So this is the pterygoid body. And so after transposition, this is the flap was transposed. This is a pterygoid body, this is a VDN, palatovaginal canal, this is a pedicle, this is a sphenoidal roof. And then once this is a V2, this is the type 3 leak where that is lateral to the V2. This is a small leak which was again closed with the multi-layer technique, and we used the flap in the final closure. So the bone, fascia, fat, and then finally I used the Haddad to help the mucosalization. So there are certain modifications of the nasoseptal flap. That is most common is the rescue flap. When you go for rescue flap, when you deal with a pathology where the CSF leak was not expecting the higher grade, you can always go for a conservative approach, right? It does nothing but you make most of the time you will make only a superior incision and rotate the flap. You will never compromise the pedicle. That is called rescue flap. Sometimes we go for both incision without making the anterior incisions. If need, just go for the anterior incision and rotate the flap. That is the rescue or reserve flap. The reverse flap, whenever you go for the posterior septectomy and Haddad harvest, we always go for a reverse flap. So this in a reverse flap, the name itself explains that the anterior cut is more posterior. It is not based on the sphenopalatine artery. It is based on the anterior ethmoidal artery. So this is a case of again, we harvested the Haddad on the right side, and we are harvesting the left side reverse Haddad. This is a superior incision already made, the left side, and we are cutting the sphenopalatine artery at the anterior face of the sphenoid. Okay, that's just below the sphenoid. We are cutting, and you can get the brisk bleeding from the nasoseptal branch sometimes. This is the inferior incision. Inferior incision completed, and when you make the posterior incision, and I will show the bleeding, see that. So this is the bleeding from the nasoseptal branch. So it's very easy to control. Once you complete the incision, rotate the flap anteriorly and cover the area, the donor area of the Haddad flap. So by doing this way, we will get a very clean posterior septectomy. At the same time, you will get the very good epithelializations, less crusting postoperatively. And very rarely we need to go for a bilateral Hadad flap, that is called Janus flap, especially when you deal with the sinonasal malignancy. This is the case of SCC neuroblastoma, where the DRAF and the bilateral transcribiform approach was used. Since this patient had a compromised width of the septal flap, so I used the bilateral Hadad in this case. This is the cribiform, which was closed with the Duragen followed by the fascia, and then fat. This is the overlay fascia. And then this is the right side Hadad. The width was not adequate because of the tumor. We need to give the adequate margin. And then it is the right side flap. Even though it's not 100% covering, but almost 80 to 90% area is covered with the bilateral flap. So what are the most common complications we encounter with this flap? Necrosis, that is very less complications. And the mucosal formation sometimes, septal perforation, of course. The posterior perforation is not a problem, but when you go for more anterior septal perforations, it is problematic. And very rarely dorsal collapse also. And there are Slavan studies that supports for the olfactory loss following the Hadad flap. Come to the middle terminate flap. So we frequently use the middle terminate flap. So what are the incision we use? One is the anterior incision over the anterior end of the middle terminate, and the superior incision on the lateral aspect as well as the medial aspect. These are very, very important. And then the incision on the basal lamella. So this is a case of cribiform defect. So how I harvest? So this is the anterior incision, and then this is the basal lamellar incision. This is the bulla. The basal lamellar incision was made, and then again I make the superior incision. And then I elevate these are very meticulous dissection we need, and at the same time don't outfracture the vertical lamella. Medial flap was raised. Usually I use the suction elevators and the microperiosteum. And this is again the medial end of the flap elevated, and then vertical lamella was removed. And then the superior incision on the medial flap was made. So these flaps based on the third portion of the middle terminate, it's a arterial based flap. So once the flap was harvested, so we house it in the nasopharynx, and it is based on the third portion. You can see the third portion where the artery enters, where this is the area where the middle terminate branch from the spinopaternal artery enters. So we preserve that. This is the cribiform area defect, which was again closed with the multilayer closure. So in this case, most of the time we need to sacrifice the middle terminate. So whenever we are planning for a sacrifice, we always attempt the middle terminate flap harvesting. This is a case of, again, this is another scenario where we will use the middle terminate routinely is the intraorbital tumor. Again, the same technique, vertical incision, superior incision, the flap elevation, this is a lateral flap elevation, this is the basal lamellar incision, and this is again the medial flap incision, this is the vertical lamella. So once in this case, we had a very good thickness of the medial flap. See, this is the medial flap, this is the basal lamella area. So once the whole of the basal lamella mucosa was preserved in this case, so once I dissected and made a basal lamella incision, and then the superior incision, and then we taken down, this is the pedicle, based on this third portion, then we housed it. So this is the tumor from the orbit we removed from between the middle rectus and the inferior rectus. After the complete removal of the tumor, you can see this is a medial rectus. So this is the after tumor removal, we replace the fat, and almost always I use the cartilage to reconstruct the medial wall. Sometimes single cartilage, sometimes multiple cartilage. In this case, I use the two cartilages. So one is on the vertical and another horizontal orientation, and you can see that the middle how we use the middle terminate flap. It beautifully covers the minimum almost 60 to 70% of the area. It helps in the rapid mucosalization of the medial wall of the orbit. So this is another case of a congenital encephalocele that is from the foramen cecum. You can see that this is the nasal root. This is the foramen cecum area. This is a 1-year-old child. So again, in this case, we need to sacrifice the middle terminate to get the wide exposure. While so before sacrifice, I tried to harvest the hadad. But in this case, the turbinate was malformed. It was very small. So here I made an incision on the third part. This is based on the second portion of the middle turbinate. So it is not the arterial based. Here it is random based flap, but it is comparatively better than the free mucosal flap because it is having some attachment with the second portion of the middle turbinate. So again, multi-layer closure, the fat, and then this is part of cartilage along with the mucosa still attached to the basal lamella. So the child recovered very well, and the follow-up MRI showed the very good taken up of this flap. And very rarely we use for the inferior turbinate flap. This is a Carew flap, that is a lateral nasal wall flap based on the anterior ethmoidal artery. I never used it till date. But I used one case of posterior based inferior turbinate flap. This is a case of sinonasal malignancy with a limited intracranial involvement. You can see the whole cribriform dura is intact, but the whole septum was gone. And here we make the floor of the nasal mucosa. This is above the middle inferior turbinate, and this is the anterior end of the inferior turbinate where you made incision. And then you elevate the flap from the middle wall of the maxilla. This is the inferior turbinate. This is the inferior turbinate bone here. And then you are going to the inferior meatus. The most critical step is the identification of the nasolacrimal duct and the sharp dissection of the nasolacrimal duct. And till the middle pterygoid, you can see that we are following the middle wall of maxilla till the third portion. And you can see the beautiful NLD. This is the nasolacrimal duct. This is the flap. Once the nasolacrimal duct was identified, we always go for a sharp cut to avoid the chronic dacryocystitis. So this is the flap, this is the maxillary sinus antrium, and you make a cut inferiorly as well as along the posterior edge of the medial pterygoid. You have to rotate superiorly, right? And it is the pedicle is based on the spinopaternal artery here. The artery is still attached here, and you go along the roof of the choana and rotate the flap superiorly. So this is how we reconstruct, and it's very tricky to place actually. So some of you placed it in that, it helps in the mucosalization. So this is how we use the inferior turbinate flap. So other flaps, nasal floor flaps, lateral wall flaps, pericranial, temporalis muscle flaps also we use sometimes. And it's a very small flap. This is not for the skull base, but whenever you go for the medial maxillectomy, you can harvest the lateral nasal wall flap to go for a better mucosalization of the maxillary sinus. So this is the left side nasal cavity. This is the maxillary sinus wall, and we are harvesting the floor of the mucosal flap. And once harvested, you can place it over the septum, and then we go for a middle maxillectomy. This is a type 2 V2 schwannoma. After that complete tumor removal, we will place the mucosa over the drilled out bone area. It will again improve the mucosalization. So the take home message is whenever you plan the flap, you plan according to the pathology and the size of the lesions and prepare accordingly. The flaps reduce the significant surgical complications like CSF leaks and the pneumoencephalus. Of course, you need to understand the basic concept of the flap, what you are harvesting, and of course that expertise is necessary, and the long steep learning curve is there, always there, and almost always aware of the alternative flaps when you fail your nasal flaps. Okay, thank you.
Thank you, sir. Before we finish the day, we have one last lecture from Dr. Dusik Singh Kong, sir, on tips and tricks on extended approaches.
Oh, good. So, hello, everyone. I'm Dusik Kong from South Korea. It's a great honor to be here. So really pleased for inviting me. And my topic is the endoscopic transorbital surgery. And the lectures will be delivered tomorrow. But today I'm going to introduce the basic part of the transorbital surgery And tomorrow, so I'm going to talk about the more detailed, advanced indications of the transorbital surgery. And actually, the Bill Caldwell says, and we have to use the tumor cavity as a surgical corridor. So we have to respect the long axis of the tumor. This is the basic concept of the transorbital surgeries. In 1980s, 1990s, we can call the skull-based field. The first wave was the open skull-based era. So many distinguished open skull-based surgeons that developed their own techniques. And next 20 years, the Pittsburgh groups, including the Danny Priveda rules, and we can call the second wave of the skull-based surgery. And endoscopic endonasal era was there. And then I think in the near future, in the next 20 years, maybe the endoscopic transorbital or the keyhole errors will be started. Who made these TONS approaches? TONS approaches means the transorbital neuroendoscopic surgery. And the first time, the Chris Moss from the Seattle, he is the ENT doctor. He made the transorbital surgeries to access the anterior cranial fossa, such as the trauma or CSF leaks, and sometimes some orbital tumors. And it's very similarly, Bill Caldwell started the lateral orbital wall approaches to access the cavernous sinus area. He removed the lateral orbital wall to access to the cavernous sinus with under the microscopic surgery. And then Jacob Dallas, 2015, he is the first person to apply this approach to the middle cranial fossa lesions, such as spino-orbital meningioma cases. And thereafter, we Korean groups applied these approaches to the Meckel's cave and the cavernous sinus areas. We are now expanding the indications of transorbital surgeries, more the various kinds of the indications of lesions. And nowadays, many papers regarding the transorbital surgery has been published now. The main concept we have to know that the transsphenoidal surgeries, today we are going to do the endonasal surgeries, only focus on the midline structures. A little bit we can access to the more lateral and lateral part, but we have to cross the carotid artery to access the more lateral part. And there is some limit of the bony structures. And you know, the sphenoid bone is composed of the greater and lesser sphenoidal wing. This is another kind of the sphenoidal approaches. We can call the transorbital approaches is the same as another kind of the transsphenoidal approaches. The basic concept, the advantage of transorbital surgeries compared to the endonasal approaches, it can provide a more direct view and shorter working depth compared to the endonasal approaches, sometimes depending on the location of the tumor. And we don't need to the cross carotid artery. We don't need the angled endoscope. Sometimes we need the angled endoscope to access the posterior cranial fossa lesions. And also we can spare the VDN nerve. And then above all, and the CSF leak is very, very minimal. Maybe 1.7% is very only limited to the meningioma cases. The other cases, we don't have any experience of the CSF leaks. To perform the transorbital surgeries, we have to take two steps. We first have to transit from the microscope to the endoscopic surgery. And also from the endonasals, we have to transit to the transorbital surgery. And this is my favorite skin incisions, depending on the species. And then we call the modified crinoline incisions. The incision is from the middle of the eyelid to the extending to the lateral part, from the lateral canthus, 2 centimeters, to avoid the frontal injury, the injury of the frontal lobe. And sometimes you can higher incisions, and also infra-eyebrow incision is okay. And then after incision of the skin, we can divide the orbital septum, orbicularis muscles. We only know the orbital septum. Actually, it's there's a very little chance to enter injury to the orbital septum, and just only we expose the periosteums over the lateral orbital rim. Then inside the periosteum and peel off the periosteum to the periorbital. This is very simple approaches, and then we know the bony structures. But most important structure is frontal zygomatic sutures here, and then This is our target. That this is a zygomatic bone. This is the greatest sphenoidal bone. This is the clinoid process. We have to know that optic canal, superior fissures. We can less the sphenoidal wing. And this is the step of how to start this one. The eyelid incisions are a little bit higher because of the wrinkle line. And after incision of the skin, orbicularis muscle is here. This is the orbital septum. It's very simple. And then expose the palpate the lateral orbital rim. Then peel off the periorbital, expose the bony structures, greatest sphenoidal wing. Sometimes we need to retract the malleable retractor, retract the orbit, but just only protect the orbit. First, we have to drill out the zygomatic bone, the lateral part, and then based on the frontal zygomatic suture, we have to cut the lateral orbital limb remover. This is the craniotomy saw. And we take it out the lateral orbital rim. It's a very small piece of the lateral orbital rim is okay. Sometimes we need to extend the extent of the orbital rim, and then expose the lateral temporalis muscles. And you see that this is the very surface of the greatest sphenoidal wing, and we drill out to expose until the exposure of the temporal dura is very simple. And then once the exposure of the temporal dura, we can remove the medial part of the temporal lobe. It's a very simple technique. And then sometimes the preoperative lumbar drainage is much easier surgery. And finally, we have to remove the sagittal crest, the medial part of the greatest sphenoidal wing, the temporal dura, the periorbital, maybe meningoorbital band is here. And coagulated dura. This is meningoorbital band, the periorbital, the temporal dura. And to reduce the orbital retraction is very important findings. We need to retract the anterior portion of the orbital glove is no problem. And also sometimes we intermittently release the orbital retraction to check the pupil size. But we have to know that the retraction of the posterior portion of the orbital glove may be very dangerous. Postoperatively, the patient complain of the visual dimness. So we need to only retract the anterior part. And also sometimes the protection is a very important thing. Use the elastic sheet. It's like to protect the nasal mucosa. And also we have to keep in mind the just protections. This is the 3D model. The superior fissure, we already removed the zygomatic bone to expose the temporalis muscles. It's very great indications for me. And then, we drill out the greatest sphenoidal wing. This is a sagittal crest. And we reversely intracranially, we have to know the anatomical structures. This is the superior fissure. This is the sagittal crest. Sagittal crest is only the lateral surface of the superior fissure. This is the maxillary strut. And we have to know the anatomical structures of the orbit. And let's see how to open the meningoorbital band. This is the sagittal crest. Yeah, here, after drilling the greatest sphenoidal wing, the removal of the sagittal crest is here. We have to remove the sagittal crest completely. Then, after removal of the sagittal crest, yeah, this is the meningoorbital band. Meningoorbital band is connection of the soft tissue between the orbit and temporal dura. After release of the meningoorbital band, we can easily expose the lateral surface of the cavernous sinus. We can introduce to the lateral surface of the cavernous sinus areas. We can perform the interdural dissections. And to do the transorbital surgeries, even sometimes this is V1 origin tumors, ophthalmic division of the trigeminal nerve can develop the schwannoma mass and extruding into the orbit. Even after removal of the tumor, the transorbital surgery, you can see the only defect of the inside of the orbit areas. The outer bone is very no problems. So at the time, initially I didn't remove the lateral orbital rim, but there is no problems to access the cavernous sinus lesions. But nowadays, a little bit bigger tumor or meningioma cases, I strongly recommend to remove the lateral orbital rim in here. And let's find the more good indications of transorbital surgeries. At first times, we just only focused on the orbital tumors, but nowadays, And standard indications of transorbital surgery is spinoorbital meningioma, cavernous, and Becker's cavum areas. And then, depending on the locations of the relationship of the carotid arteries, inside the medial part, we perform the endonasal approaches. Pteropalatine, infratemporal fossa areas can be accessed with the endonasal route, but frontal part and anterior cranial fossas can be accessed with the supraorbitally. But only transorbital approaches mainly focus on the temporal lobe and cavernous sinus portions, is so-called middle cranial fossa lesions. And how to reconstruct after the transorbital surgeries. Usually, we favor to use the Duragen and sometimes the fascia lata, so allodermal graft materials. And after removal of the meningiomas, I always place the fat graft harvested from the abdomen. And this is let's see the indications. The most common indication is middle fossa meningioma, and next indication is cavernous sinus lesions, and third indication is temporal parenchymal lesions. I'm going to talk about only the meningioma and schwannoma cases today. The first indication is middle fossa meningioma. The spinoorbital meningioma may be the best indications of these approaches, but clinoidal meningioma, sometimes the spinoidal rich meningioma, cavernous sinus, the lateral wall origin tumors, and petrocleval meningiomas can be accessed with the transorbital surgery. And as I told you, recently I changed my surgical techniques. We added the lateral limb removal is much better to obtain the wide working space. It allows free maneuverabilities. And removal of the lateral orbital limb, we can access the more lateral part, and also we can access the more, it allows the acute angle of attack to access the orbital tumor. And also, sometimes very deep-seated lesions can be accessed with after removal of the lateral orbital rim. And we compared which one is better, of course, and lateral orbital rim removers can provide more wide working space. The first topic is the spinoorbital meningioma. We have successfully removed the spinoorbital meningioma or temporal lobe tumors with the transorbital route. Even after some tumors invading into the orbit and then involving the periorbital or extraocular muscles and sometimes invading into the infratemporal fossa lesions. And then we published our data about the transorbital surgeries. And the mostly good let's go. And this is common. I don't like the head fixations, only the place the head under the horseshoe, and then we perform the transorbital surgery. This is not the real spinoorbital meningioma, only the middle cranial fossa meningiomas accompanying the peripheral edemas. Of course, and maybe the transcranial approaches may be better, but instead of that, I performed the transorbital surgeries without touching any brain. After operation, yes, we performed the incision. We performed the modified coronary incisions. And after dividing the orbicularis muscle, that is orbital septum, then we can palpate the lateral orbital rim. It's very simple. And expose the greater sphenoidal wing and placing this is first, I remove drill out the zygomatic bone. This is the frontal side, upper part and lower part of the lateral orbital rim, and we removed it. And expose the temporalis muscles and drill out the greater sphenoidal wing. This is the medial part of the thickened hypertrophy of changes of the tumor. And finally we remove the tumor, and then just only the other part is only same as transcranial approaches to be safely without touching any brain. A little touch of the peripheral brain, but without any retraction of the brain, we successfully remove the tumor. After operations, here, and place the Duragen, fat graft materials, and fixed with the titanium plate with the lateral orbital rim. And finally, we sutured the continuous sutures with 5-0 or 6-0 observable sutures. After operations, you see the total section was achieved, and then there was no the cosmetic issues. But we have some experience of the fatal experience, not fatal, but maybe some incomplete resections because of the many tumors are very widely spreading. We have to know the dural margin is a little bit thickened, so we have to select the best indications of tumors. And sometimes, and without any removal of the lateral limb, it's very difficult to access the more lateral part. Sometimes the infratemporal fossa has many limitations to do so. So nowadays, and we announce the more narrow, select the narrow indications of this tumor. And next topic is trigeminal schwannoma. A little bit, I think all participants must be very tired, the long day, the cadaver dissections. And it's a very short talk, and I'm gonna continue the next story is tomorrow. And this is the good indications of transophthalmic surgery. Trigeminal schwannoma is the best indications of transsurgery and transophthalmic surgery compared to the meningioma cases because the schwannoma is very suckable, is easily friable. How about the posterior cranial extending the tumors here? We performed the transophthalmic surgery and maybe type C, the middle and posterior dumbbell type of the tumor. We selected the transophthalmic surgery and incision here, exposing the greater sphenoid wing. And we don't have to do the dissection of the meningoorbital band. Then expose, this is meningoorbital band here. And exposing the interdural dissections, the access to, it's almost same as the orbitozygomatic approaches. Sometimes the orbitozygomatic approach is, maybe my concept is, this is a small size of the orbitozygomatic approaches. The indication is almost the same as the COG, the cranio-orbitozygomatic approaches. We can easily access the middle craniofacial lesions, and then just only follow the tumor axis. And then through the porous trigeminus, we can access the posterior craniofacial lesions. And finally, we can access the anterior surface of the brainstem. We just follow the tumors, there's some fascicles here. That is, we remove the middle craniofacial lesions here. That is a pulsation of the tumor. But this is enlarged of the porous trigeminus, entry point to the posterior craniofacial fossa. We remove this one here. This is a cisternal segment of trigeminal lobe. Maybe that is the brainstem of the pons, maybe here. And after removal of the tumor, we can see the anterior surface, the oculomotor nerve. In many cases, it's very difficult to identify the oculomotor nerve because the oculomotor nerve, in many cases, displaced abroad. It's very difficult. We need to see the angled endoscope to identify the oculomotor nerve. And the reconstruction technique is very simple. We don't have to use the fat graft materials for me, but my colleagues is favored to use the fat graft materials, but it's very simple. It depends on the surgeon's preference. Only the observable sutures, subacute suture, only the small incisions. This is maybe last one, After operations, you see we achieve the total resection here. And immediately after operations, and then which one is an operation site? Nobody knows that. Even the patient doesn't complain about that. Yes, I will continue tomorrow. Thank you for hearing me.
Thank you so much to all the faculty members for the extensive and educative lectures all throughout the day. I would request all of you to please proceed to the porch area so that all of you can be coordinated well to your hotels and thereon to the gala dinner venue tonight. Thank you.